Okay, we'll go ahead and get started. So an overview of today, we'll go over introductions, the need for APMs, and then peer support and alternative payment models. As I mentioned, if you have questions, feel free to type them into the chat box, and we'll have some time at the end to review. So our presenters today are Nathaniel Counts. Nathaniel is the Associate Vice President of Policy for Mental Health America, where he works on innovative federal and state policy solutions for problems in behavioral health. In particular, he focuses on issues in incentive alignment and sustainable financing in behavioral health care, as well as issues in population health. Nathaniel is an expert member of the Forum on Promoting Children's Cognitive, Affective, and Behavioral Health at the National Academies of Science, Engineering, and Medicine. And he serves on the board of directors for the One Circle Foundation, the Anne Frank House, and the Flawless Foundation. Nathaniel received his JD cum laude from Harvard Law School, where he was a Petrie Flom Center for Health Law Policy Student Fellow, and his BA in Biology from Johns Hopkins. His most recent publication was Expected Value-Based Payment from Total Cost of Care to Net Present Value of Care in Healthcare, the Journal of Delivery Science and Innovation. And I'm Kelly Davis. I'm the Director of Peer Advocacy Supports and Services at MHA. I work on the expansion of peer supports about healthcare and lead work on peer support and consumer advocacy among young people. And I will hand it over to Nathaniel.
Thanks, Kelly. So hi, everyone. So the first question is, why positive alternative payment models? It's a lot of work and effort, and there has to be reasons for all this. So the core issue is fee-for-service healthcare, where you pay for each unit of service, fundamental service. One of the biggest issues is idling costs. And there's a reason, I think, a couple months ago where it looks like the cost is leveling off a little bit. But the recent projections, today healthcare is about $3 trillion. So the most projections from I think this month were at 5.4 trillion dollars, and about a pretty decent percent of our entire economy. So that's clearly not sustainable. And the other big thing is that our outcomes for the incredible amount of money we're spending are not very good. So even though we spend the most out of most of the highest income countries, our outcomes are not quite what you'd expect. And on top of that, we also have incredibly stressed out providers. So clinicians aren't doing well, patients aren't doing well, and the sort of total budget is not doing well. So something needed to change. And so the big idea here, and this started, I think, in 2012, was the Secretary of Health and Human Services said, we're going to start transitioning from volume, where we're paying based on fee-for-service, to value, where we pay based on outcomes, and set clear goals and metrics. And the big thing is, even though now we have a total transition in administration, so turnovers in Congress, the movement towards value-based payment stays as strong as ever. And the commitment, I think, to change, it's not a question of whether we're going to move to value-based payment, it's when and how. Most recently in 2017, the Healthcare Payment Learning and Action Network, which is the public-private partnership that kind of marshals this transition along, found that 37% of all payments were in advanced alternative payment models and growing every day. So, and that's up from, I think in 2012, it was probably like 1%, if any. So there is actually pretty rapid transformation. So this is coming. This is just a slide stolen from the Healthcare Payment Learning and Action Network, showing this is what health insurers think about alternative payment models. So you can see people really do believe that, the health insurers are invested in seeing value-based payment move forward. This isn't just a fad. So as exciting as all of this sounds, it's also hit a variety of snags as it goes along. One of the biggest issues is a lot of the high-profile evaluations of the first waves of alternative payment models did not find that they were reducing total costs.
So, for example, one evaluation of a bunch of the different alternative payment models found that as a whole, costs didn't go down across those populations. And then one that looked at the overall prevalence and penetration of payment models found that they were not reducing costs in the areas in which they were implemented. The most recent study, New England Journal of Medicine, on accountable care organizations did find some reduction in costs, but only in some subtypes of APMs. So there have been real problems to date with how this is rolling out. And most notably, it has not done well in behavioral health. An article in Health Affairs in 2014 found that most accountable care organizations had not done anything significant in mental health. They were not looking at any new investments, any major transformations there. And when you look at behavioral health outcomes, so sadly in healthcare we don't measure very many outcomes for anything, but we do, of all the things, measure depression outcomes. So the way we measure it is over a 12-month period, what percentage of people reported not being depressed anymore. And so in just a normal population, if you have a certain number of people experiencing depression, usually within 12 months, absent any intervention, about 53% of people will get better just naturally. You know, it's like depression's kind of cyclical and it comes and goes. In the accountable care organizations, they found that only 8.7% of people got better. So that's 40% worse than random. And the real reason I think isn't that it's making people sicker, it's just that people aren't really tracking outcomes really meaningfully at all. Like basically alternative payment models, it's not clear if people with mental health and substance use conditions are getting better. And part of the thesis here is that mental health and substance use conditions are huge cost drivers. Some of the most expensive people in all of healthcare are people with mental health conditions plus a second comorbidity like diabetes, hypertension, some other chronic condition. So that's both the most expensive people, and we haven't undertaken any serious delivery system reforms in response to that. So part of our thesis here at Mental Health America is that that's what's needed in payment reform is serious attention to improvements in the mental health and substance use delivery system. And so even though there's a lot of effort to like slightly better coordinate things, unless we actually see some fundamental changes in the services delivered, we think it'll be hard for payment reform to be successful.
So peer support, as many of you know, peer support really got started in public behavioral health in the 1980s, and in the past 10 years has seen rapid expansion, although that's primarily existed in Medicaid and using state and local dollars. But what we've seen so far is that peer support reduces the highest cost of services from hospitalization to emergency department use, has better outcomes, including improved quality of life. People feel more engaged in their treatment, and people feel a greater sense of hope and more connected to their communities. And one of the other really important outcomes, going off of what Nathaniel mentioned, is that there's such a high amount of folks who have mental health conditions and other chronic health conditions. And peer specialists have been really, really helpful in helping to teach people how to manage their other chronic health conditions, which is one of the things that drives up a lot of the costs in healthcare. Peers also work in a lot of settings. So in their history, it was a lot of use in peer-run drop-in centers and community mental health, but we're now seeing peers in primary care, in emergency departments, and in new crisis services and crisis settings that are popping up and expanding. And in addition, peers are really a key opportunity to address the behavioral health workforce shortage. So across the country, there's many areas where there just aren't enough providers to meet demand, and adding peer specialists with their ability to work in lots of settings and improve outcomes and reduce high costs, we feel they're a really, really important part of addressing the shortage that we're seeing in so many parts of the country. So from the early history of peer support, it really focused on many of the leading concerns that we're seeing now as shaping changing healthcare financing, like reducing the use of high-cost services, keeping people out of the hospital, and improving overall health. So not just symptom reduction, but how can we teach people skills to manage their physical health, their emotional health, their relationships, and how can they self-manage their struggles and their challenges and other health conditions they may have. As I mentioned, they're primarily in public mental health, and traditional payment models, so fee-for-service, and there's been really limited access and limited expansion beyond where, using peers in inpatient psychiatric units, it's often a point where somebody is really, really not doing well that they get access to peer support. And it fits poorly into fee-for-service and is really aligned more to fit into APMs, where we're looking at not just how much does it cost to deliver this unit of care, but how much does this cost overall, and where are we saving money, and how can we consider that in what we emphasize and what we build out.
Some of the accountable care organizations, for example, which is the model we'll get into in a minute, they have begun to hire, at least in some cases, community health workers, which is like a general kind of new allied health professional kind of activity for things like asthma abatement and some sort of like medical complexity in aging populations, but we haven't really seen analogous activity, I think, in mental health and substance use. So I think that some people have begun to see the opportunity in other conditions, but it has not been leveraged yet in people. So sorry to hit you with an extremely dense figure all at once, but I think to kind of get the gist of the trajectory, the categories, the complexity of alternative payment models, we wanted to put up the Healthcare Payment Learning and Action Network, which I mentioned before is the public-private partnership between providers, payers, HHS itself, to move forward value-based payment, put together this 4-category framework, which looks at category 1 on one side, which is fee-for-service, no link to quality or value. So that's just your traditional, like every unit of care I get, I get X amount of dollars, and then that's my entire incentive system. And then you can see how when you move along, it kind of gives you a stepwise transition as you move towards like, okay, now we're doing fee-for-service, but we got a little bit of additional data and performance information as we go, and maybe I get a little bit of a bump if I hit certain quality measures or hit a certain cost outcome. And then in 3, you start getting more interesting models where you get to share savings if you achieve savings, but also get a little bit on the hook if you don't achieve savings. And then category 4, you get even more interesting models where you get like total flexibility for funding. And so this is the kind of like landscape of where APMs fit, and then to kind of make this a little bit clearer, we're going to go into some details about specific APMs, and then where we see opportunities for peer support, even though to date they haven't been leveraged, even though we think that it'll be like absolutely critical, I think, to hitting the cost and quality goals. So we're going to go through 3 kinds of models today. The first is population-based payment models, which we'll get into a little bit more, but just generally, that's where you're managing, like, let's say you're like assigned 1,000 people out in the world, and your job is to manage their entire health for the year. That would be the kind of the gist of a population-based payment model. Then an episode-based payment model, it's not entire population, it's everyone who has shares a certain event or has a certain health condition. So it's everyone who had a heart attack, and your job is to hit certain cost and quality goals for that event. Or in our case, everyone who had a psychiatric hospitalization. And that would be sort of what the payment model is designed around. And the third one is kind of like the Wild West a little bit. Social determinants of health as a concept has been around for like decades, but in healthcare financing, it's the new hot thing. And there's been a couple payment models developed around it and a bunch more in the works, and we can't go to a meeting without someone talking about it these days. So the model design is a little bit less clear, but there's a there that peers fit into. So we want to talk about that. So getting into population-based payment models. So we mentioned there's originally an idea where it's like for each service we do, we get a few bucks, and that's how healthcare works. This is totally different. When you do it right, it's here's a person with a certain level of need that we understand, and here's a certain amount of money per month you get to manage that person's healthcare. So we won't be prescriptive about what all you have to do, but we'll give you the flexibility and the financial resources you need to do a good job in managing that person's total health. And then there's certain incentives placed on it, so if you're able to reduce total costs based on what's expected and hit certain payment outcomes, then you get bonuses. And so I'll get more into why that's so important for peers, but yeah, here we go. So you kind of see in a kind of payment model where you have that level of flexibility, and your goal is to improve on care by better managing their needs and sort of making sure things don't get so dire that they have to use the emergency room or other health needs don't spiral out of control. Having someone who can provide a more consistent source of support and warm touch, like a peer support specialist, could be absolutely invaluable, especially for managing outcomes and costs associated with comorbid mental health and other chronic conditions, which do end up making up some of the largest spending for people in population-based payment models. Oh, and just to put an even finer point on that too, which I think Kelly will talk about a little bit more later, is in the current system where we often have like just dramatic problems with coordination, having someone you can contact and trust before you reach crisis, as we say here at Mental Health America, before stage 4, just sort of like in a very like obvious, intuitive way can prevent emergency department utilization. If you have the opportunity to contact someone hours before you go into crisis, they can work with you to make sure you don't need to go to the hospital. And that's better for the person, better for the provider, better for the healthcare system. So here's the sort of like biggest example of a population-based payment model. And there's actually not that many ACOs in this exact format, but this is sort of where the ACO program I think is going to be going in the future years. And so the basic idea is you have a bunch of providers who agree to take on accountability for a bunch of people. So they get these per member per month payments based on a group of individuals that that both the individual agrees that they'll want to see these people in these ACOs, and the people in the ACOs agree that they should be accountable for it. Providers in Detroit don't want to be accountable for someone in Baltimore, so it's kind of working out that kind of thing about like how do you make sure that these are actually people that make sense for you to take care of. And so you get attributed and you get these per member per month, and then your job is to hit certain quality metrics like making sure you have certain rates of depression screening, making sure you're managing comorbid diabetes issues if someone has schizophrenia. Like all of these are quality measures kind of baked into this performance measure set. And so if you're able to hit certain quality measures, then you get to share any of the savings you have on top of it. And this is different than the way that previous attempts at payment reform worked. So if people remember kind of how HMOs worked, where there wasn't as much of a focus on quality measures really, and often people felt like a lot of the savings were being achieved through just providing less total services. And so the goal here is to make sure that like the only way you can get savings is by doing better care, not by just not giving people care. And so in a world where you have to figure out how to do that, we think peer support specialists could be really valuable. And there's other population-based payment models as well. So like ACOs are sort of the big ones that everyone talks about. But there's also a bit more and more advanced primary care models where instead of having this like huge network of physicians taking on accountability and sharing it across all of them, it's more a single provider group or a primary care group kind of managing your health of a population for people who make sense for primary care to do that. And then they're also toying with other models where maybe you can have like a community mental health center take accountability if mental health and substance use conditions are really your major concern, and then they can also help manage your medical, like non-mental health and substance use needs as well. So onward to episode-based payment models, which I already kind of alluded to. So if instead of per member per month for a whole population, like we just saw in population-based payment, episode-based payment instead is here's the cost of whatever the event or condition is we think it should cost. So we think that based on all available data, an episode of heart attack care from first entering the hospital to 60 days after you leave should cost X amount of dollars. And that's the amount of money we give you up front instead of just a per member per month for everyone in it. so your goal then is you get like the blob of money up front, and then you get incentives based on whether you hit certain performance goals and if you're able to reduce costs relative to expected, because kind of baked into this is a certain assumption about inefficiency. Like, you know, back before we had this and had fee-for-service, there wasn't that much incentive to really coordinate. Once you leave a hospital, do you get outpatient care, and are all of your different needs being met, and does everyone know about your medications and everything? So the goal is to, like, it's kind of showing that there's certain inefficiencies in it and incentivizing you to solve them. So a lot of the original bundle payments really focused on heart attacks and joint replacements and all of this kind of non-mental health things. But there is a sort of obvious role, I think, for bundle payment in episodes of inpatient hospitalization related to like psychosis or mood disorders, where it creates like real incentives for you to manage someone's needs after they leave the hospital and make sure that they get coordinated care and get good outcomes at reasonable costs, rather than just, you know, released into an abyss of uncoordinated services where let the cards fall as they may, and maybe even get rehospitalized within a couple of weeks. And so going from there, okay, so then I'll turn it over to Kelly to give some more kind of specific examples about how all this could work.
Yeah, so I'll give everyone an example of a pilot that we did through MHA, and then a different model that's popping up in a lot of different states around the country, just to note in response to someone's question about the research. At MHA, we run the Center for Peer Support, where we have a whole host of new research and summaries of what's out there, both programmatically and research-wise in peer support, and that's just centerforpeersupport.org. So I'll go over, we did a pilot with Hospital Corporations of America in Palm Beach County, Florida, where we worked with the national office, our local mental health affiliate, and the HCA. So the peers met people who were hospitalized in the psychiatric inpatient unit. It was all voluntary. One of the core aspects of peer support is that it's voluntary, and they followed people into the community. So meeting with them when they were in the hospital, building relationships, helping them think through not just what are my treatment needs and what am I supposed to do after I'm hospitalized, but like Nathaniel mentioned, where can I get my medication? Do I have transportation? What am I going to tell my family? Can I address the conditions that may have led to me being hospitalized? And all of the things that aren't necessarily included in a treatment transition plan, but also that just might not be considered. And many of us know that, you know, the highest risk you are for suicide is following a release from the inpatient psychiatric unit. So it's a really, really sensitive time to support people and ensure that they have a healthy transition, both in terms of levels of care, but just as human beings in the support that they need. And in this pilot, we saw significant reductions in rehospitalization and improved well-being. And we look at the PHQ-9 scores and person outcome measurements. And you can see a little chart here, rehospitalization. We worked with folks who had a high rate of prior hospitalizations. Their rehospitalization rate prior to the peer empowerment program was 46%, and then following it decreased to 13%. And these were folks who had really, really high healthcare costs beforehand. So really helped to reduce the overall cost and shift the services into the community, but also their ability to just fully be a part of community life. Another model that is really interesting and can fit into here are peer-run respites. So peer-run respites are safe, home-like places for people to go voluntarily during times of distress. So they are alternatives to hospitalization. So instead of going to emergency department, instead of getting placed unnecessarily in an inpatient psychiatric unit, they just look like houses. They're run by peers. People can go into them for days if they need to, just get away from things, have some support, think about what could help them. They don't offer medical services like medication management, but research out of especially New York, where a lot of them started popping up, shows that they're really cost-effective alternatives to hospitalization, and they can improve people's short and long-term outcomes by, giving people just a safe place to go where they don't end up caught up in either unnecessarily hospitalization or kind of run into the same problems that many folks who do experience inpatient hospitalization have.
And it's pretty easy. I didn't realize this was like a lot of health report on this. And you might be like, oh, I bet it's pretty high. And unfortunately, about 45% follow up after hospitalization. This is like after like a suicide attempt, after like a acute psychosis. 45%. And it has been stable for years. The more horrifying thing I even realized recently is that, oh sorry, I saw some of you couldn't hear. So I was just saying the follow-up after hospitalization for mental illness across the country is about 45%. So after someone's hospitalized for suicide attempt or schizophrenia, a psychotic episode, 45%. And even more horrifying, apparently some proportion of those too is actually if on your way out of the hospital you have your appointment in what's considered the outpatient part of the hospital, that can count. So actually, in reality, the rate of meaningful follow-up for hospitalization after mental illness is probably just exceedingly low. And there's another good example too. Is for suicide prevention after a suicide attempt, if you send a note home wishing the person well, it significantly reduces the likelihood of a repeat attempt. And the kind of issue is, like, in a fee-for-service world, everyone's like, well, how do we do these things? No one pays us to do these, and we don't have the staff and resources. And in an alternative payment model world, peer support specialists can do all of these things. Help make sure people get connected to care, make sure we implement support interventions we know they're so effective. And there's just such a long way to go that I wanted to highlight that further. Oh, man, now back to me. So there's a growing appreciation. I mean, it's been around for years, but I think as like costs continue to spiral and outcomes do not improve, despite a lot of good attempts at reform, that so much of health is outside of the clinic. I mean, we can come in for a 20-minute visit or 40-minute visit, but the rest of our lives, 24/7, 365, is really, in a lot of cases, what ends up determining our health and our costs. And so, and just like the absolute easiest example that people go to is asthma. People can go to the hospital over and over again for asthma attacks, but if you just improve the conditions for their home, get them air conditioners, things like that, for like $400 or $1,000, you can prevent tens of thousands of dollars in hospitalizations. And so the same thing is true, of course, in mental health. And in order to accomplish these goals, a lot of healthcare systems are partnering with community-based organizations. So outside of mental health, for example, if you're worried about aging populations and falls and social isolation, a bunch of different Medicaid plans across America have begun partnering with their local area agencies on aging, and even creating like integrated data systems and payment models that incorporate everyone. So I just want to go to a concrete example. So one of the biggest models in this space, the government's testing right now, I think it's about $150 million investment, is called the Accountable Health Community Model. And that was sort of quietly groundbreaking, I would say, and really interesting in that it funds through Medicare a nonprofit like backbone entity in the community. So it can be like a community health organization or a data exchange, or it can even be a community health center or a Medicaid health plan, for example, or Medicare Advantage plan. But the idea is when you go into the healthcare system, they screen you now for all sorts of what they call health-related social needs. So that could be housing insecurity, food insecurity, mental health conditions, loss of family and social support. All sorts of different needs that people may face that end up affecting their health. And then through this backbone organization, this third party, they then connect you with other community-based resources that can actually help you meet those needs. And so when you're thinking about mental health and substance use, there's a clear role, I think, for peer-run organizations that can be those community partners. So, in the easiest example,
Kelly just talked about peer-run respite, if they were one of the organizations involved in the model, then when someone goes into the healthcare system through inpatient psychiatric admission, then they can be immediately coordinated with peer-run respite, know that that's an option, and even if we get really sophisticated, have transportation over there, and then as they're leaving respite, get coordinated with the rest of the services they might need as they return back into community life. And there's a lot of opportunities. So the actual payment models around these kind of collaborations are still pretty weak, but there's a lot of different opportunities, I think, to share incentives with these different community-based organizations, giving them a chance to, get additional funds as they hit certain outcomes and help with overall savings that really could be explored further.
So another example of this model that we've worked on through MHA and another pilot with Kaiser Permanente and one of our affiliates in Northern California was a program we did in their outpatient setting with 2 full-time in-person and telephone-based peer specialists. So we worked in an outpatient setting for individuals with multiple chronic health conditions who were both on Medicare and Medicaid. And they added peers to their critical care team. So all of the other doctors that they were working with, peers just became another important part of that process. And it was funded through their Special Projects Fund and is now transferred to their HMO. But as Nathaniel mentioned, it was really focused on not just providing one-on-one support, but connecting people to all different kinds of sources or services. So you can see in the graph right there, all the different things that people were interested in, their goals, and whether they were met or they were in progress. So not just mental health, but housing, finances, home safety, isolation, food, pain, and a bunch of other things. And over the course of a year, what we found was that the increase or the added peer support, increased team collaboration, had better linkage to care and resources. So folks had better relationships with their providers. They felt more engaged and involved with the KP system and were better able to access all of the different things that they needed. They were able to identify and meet their own needs in the community and address the traditional gaps post-discharge and improve their activation themselves to say, okay, these are the different things I need and these are the things that I can do. And with 2 full-time, just an example of how powerful both in outcomes but in cost savings, with 2 full-time peers, they had over $1 million in savings in the first year. So it's not just, we think this is a great idea, but it can also have you're seeing that it's having a really dramatic impact when it's being used. And to go off of that, one of the things that we're working on here at MHA and has been part of our program is our National Certified Peer Specialist certification. So when we talk about peer support, there's a huge variety of, what experience and knowledge a peer is going to come in with depending on where you are in the country. So in some states, it's a 35-hour training and they get a certificate. They don't have, there's no experience requirement, and then they're able to provide services. New York State, there's 2,000 hours of experience before you can get certified. It's a whole wide range of knowledge, and in a state like California, it's even county to county based because there is no state certification. And one of the major barriers that we found to expanding peer support beyond its traditional roles and its traditional funding mechanisms was a lack of a high uniform standard that folks in the healthcare sector making decisions could rely on. So our NCPS launched after years of development and feedback from thousands of peers across the country in partnership with the Florida Certification Board, meeting all of the standards for a valid, legally defensible certification, created a national uniform standard for peer support with a high level of skills and experience. So it builds on top of existing state certifications. So folks who are in states with certification have already had to achieve that with a minimum of 40 hours training, a minimum of 3,000 hours experience, multiple letters of recommendation, and passing of a 125-question exam that includes things like not just, how to support people, not just the history of peer support, but how to work as part of a healthcare team, and really focused on integration into healthcare teams in the private sector, especially APMs, with their large focus on flexibility, coordination, and population health.
So our takeaways then, in order for this entire endeavor to improve outcomes and reduce total costs, alternative payment models need to drive important changes in the way we address mental health and substance use care. Better care coordination among the things we already do is great, but I think we won't get there unless we really build in new capacities to more fundamentally transform the way we deal with mental health and substance use. We think the data really bears that out from the way we've seen alternative payment models go thus far. And we think that in the world of meaningful changes in delivery systems, peer support specialists offer a really important addition. They thrive in the kind of flexibility that alternative payment models enable as opposed to traditional fee-for-service, and really play into, I think, the key both performance outcomes that these APMs are looking for and the desire to reduce total costs through unnecessary and preventable medical complications. And within the realm of alternative payment models and peer support, the national certification can really help with uptake. It's really hard if the standards are different everywhere when you're a national health plan trying to roll out APMs across multiple markets. Having consistency and making sure that people are practicing in similar ways is enormously helpful. So with that, we wanted to go on to questions. People want to take one?
Yep, so we have about 20 minutes left. I'll go and review some of the questions that have already been asked, and let's see. So our first question from Jim, considering the private sector, what are the most pressing barriers in not having private insurance companies reimburse for the peer support perspective? So
the biggest issue with not having private sector reimbursement is no one in the private sector can access peer support. It's sort of like instantly, only people with Medicaid right now can get any access to peer support specialists of any kind. So if you're in commercial plans or Medicare, you just don't get peer support. And then more systemically, that raises the issue that if there's not funding streams coming from commercial and Medicare, then peer support as a whole ends up being a relatively limited field. Even within Medicaid, they're usually paid through different kinds of pots of money that aren't traditional reimbursement methods. So it's sort of a field with a lot of potential that just goes completely untapped because we haven't figured out the financing to date.
And on that note, what I was just talking about, so obviously there's a serious impact on people looking for support and help in the private sector not having access to peer support, and that's really one of the drivers of us developing the national certification. So looking at national payers like Medicare and other commercial insurance companies, their major concerns in our discussions were a lack of uniformity across the country and a lack of a consistent high standard. So the national certification was developed with the expansion of peer support, both in sectors, in settings, and also for career opportunities for peer specialists. So not just an entry-level job, maybe in a community mental health center in the way that it's paid for now, but really opening up options so that peers are aligned with the way that the future of healthcare financing is also moving. Next question. So as I mentioned earlier, so Trevor asked, do you have a list of the studies you're pulling this from? MHA runs the Center for Peer Support, so more information about the history of peer support, MHA programs, comprehensive research and workforce issues are all available at centerforpeersupport.org. Let's see. Yolanda asked how many respite houses are there currently. I don't know that number off the top of my head, but the National Empowerment Center does keep a list of the consumer organizations across states, and then they also have information about respites, and their website is power2u.org. Ladiana said, can you comment on your ideas, thoughts, or expectations regarding peer recovery specialists, and in particular those with substance abuse histories? I've heard great things about this, but some have criminal backgrounds and would not fit some of these criteria, I'm guessing, meaning the NCPS. Criminal background does not preclude you from getting the national peer certification. That's definitely something that has come up a lot in our pilots. Is something that we address with the folks that we're working with, is that many of the people who are providing this really, really valuable resource do have criminal histories or prior convictions, and that does not preclude them from working in our pilots or in our national certification. Yeah, exactly. So criminal backgrounds, one of the big places where people are using peer support right now is in correction settings. So both working with people when they're in corrections and also helping people transition back into the community. Our MHA affiliate in Nebraska, Mental Health Association of Nebraska, does really, really awesome work with corrections and helping people transition back into the community.
So, and one of our next great questions from Amber is about what do you do when there's such a low rate of peer support that it's hard to get a managed care organization excited about this when it ends up, it's just like such a small issue and such a vast machine. And I think then it's really about building attention for the entire ecosystem. So there's the managed care organization, but then there's also the state, which is the major payer for Medicaid, and designing the sort of request for proposals and all the incentives around the managed care organization. So I think where it's too hard for the managed care organization, who has to be working on a bunch of other things, to really get into the details of peer support, then it's working with the state to make sure that as they're engaging with Medicaid MCOs in the future, building in more support for them to take on peer support in the future. So Heather asks, do you offer any support or guidance for employers who wish to implement a peer support program for employees? So I'll let Kelly take on some of that. But our thought is, I know it's really hard for any single employer to push for sweeping healthcare reforms. For a health plan, you're one of hundreds of clients who are buying their plan, unless you're in a RISA plan. So it can be kind of hard, but I think through employer coalitions like the regional business groups on health, there's a real chance to work with insurers to offer plans that do value-based payment, and that do value-based payment that supports peer support specialists. I think having those conversations really early can be really helpful. And getting people thinking about it. We know, there's business coalitions across America that are really making mental health their #1 topic, like Minnesota, for example. And so I think as people are thinking about things like quality measures and collaborative care and all the other sorts of things in mental health, making sure peer support is on the list is going to be really helpful. So Nina.
This is Kelly. So on a more employer-specific answer, in all of our pilots we've found, and many of the folks who work in peer support find that it's really, really important to train staff in any organization to understand what peer support is, what they do, and what they don't do. Otherwise, there's a lot of confusion, and you will throw people in a program who no one's prepared on how to work together, and that doesn't work as well as having someone come in beforehand and kind of explain everything to everyone. So I'm certainly happy to, I have my email at the end of the slide. I'm happy to talk to you. And then for our national certification, we have training partners across the country who we connect people with, some of whom do direct support and training for organizations that want to begin to implement peer support.
And so Nina asks, in APMs, do peer support specialists have more freedom in how service is delivered than in fee-for-service? And yes, so that's the that's the dream of alternative payment models, is it gives you the flexibility to deliver the care that's needed to get the best outcomes at the lowest possible cost. And ideally, it's, this per member per month kind of payment that can be distributed in a way that makes the most sense. Instead of, as I know happens in some states, like 8-minute increments, which does not really capture the complexity and art of what peer support aims to do. So yes, that is the goal of it. Thomas asked the great question, how much of the savings are due to peer specialists being underpaid? So the point we're trying to make here is not that we should sub out existing services with lower paid peer support specialists as a way of cost saving. Our thesis here is that the services delivered by peer support specialists are so valuable that they improve outcomes and reduce costs. And I think we didn't really get into this, but a critical part of that is paying people based on the value that they produce. When people are making, like saving like $1 million a year with 2 people, so each person saved $500,000, then it goes without saying, well, I guess probably have to say it really often, is that people should be paid fairly based on what they're doing. The savings is not just from having people doing the exact same thing while paying them less.
One of the things we talk a lot about with the national certification, because I do hear that a lot, is like, oh, peer support will just be used as substitute labor. There's plenty of parts of the country where peers are paid well, but there's also plenty of parts of the country where peers aren't able to work full-time, or they're being paid, $7 an hour, and there's nowhere for them to go. And that's part of the rationale for us developing the national certification, is to try to grow income or salaries for peers and create career opportunities that aren't just these entry-level jobs. And the really, really specific messaging is that peers don't save money because you pay them less. Peers save money because they do a good job. And we can demonstrate that in something like our Kaiser Permanente study, where it wasn't just peers replaced some other more expensive provider, but they're not replacing some provider. They were added onto a team, and because what they do is so unique and engaging and important, they saved a significant amount of money that other providers weren't able to do. And then to Stephen's comment, there's plenty of folks in the peer support world who are volunteers, and we certainly, especially with our national certification, peer support for any and everything is really helpful, and we're not here to say that everybody should make a career out of peer support, but we do believe that there should be more opportunities and more integration of peer specialists who do want to work in the field.
So Malka asked a great question. Could you comment on a few leading states you know of in peer support legislation, alternative financing for peer supports? So unfortunately we cannot, and that's partly the goal of this webinar, is we're hoping to work with all of you to make it so there are a few leading states in peer support financing for peer support. I mean, there's plenty of states leading, all sorts of amazing payment reforms, and plenty of states doing peers well, and sometimes those are even the same states. But I think for just so long, peers were paid for by county funds, and like Medicaid reimbursement is I think in the timeline relatively recent. So I think people just really haven't put it all together yet. So that's sort of the critical opportunity we're trying to highlight here. I mean, plenty of states are ready. Like New York State has been doing so much work in value-based payment redesign and has like a lot of peer support that it's like all the trappings are there. And Colorado's undertaken a lot of work. In Washington State, I think it just takes leadership on the ground to make sure that it actually is implemented well and that the payment models make sense ultimately.
So Jim asked, is there any proactive marketing taking place to insurance companies to help them understand the value of peer support? That is something that we are spending a lot of time on out of the national office, reaching out to private health systems and commercial insurance plans and provider groups to teach them about peer support, the fundamentals, how to integrate peer support, the real cost savings, and that not just underpaying people, but that they do something unique that's really valuable. So there's definitely other local groups that I'm sure are working with our folks, but from a national level, that's something that MHA has been doing and will continue to do. And Trevor asks, I'm interested to learn more about these cost savings and value provided by peer support specialists. Is there a place I can look at the data? Is this also provided on your site? Yes, so on our website, we have a bunch of, we have information about all different workforce issues, all different recent studies, and then we also have a summary of basically all of the major research and peer support. So like, where can we see that it reduced hospitalizations? Where did it reduce costs? How did it reduce costs? And how did it improve overall health? So we have a large summary on there that you will be able to find that can show you all of that information. And then Alex said, can you share the Kaiser Permanente study? So I do have a summary that I can share on that as well. And then we'll go to the next slide. That is my email. It's kdavis@mentalhealthamerica.net. I can share any and all information, or I'm happy to talk to anybody about peer support. Nathaniel's information is available too. It's just ncounts@mentalhealthamerica.net for folks who are more interested in the intricacies of healthcare finance and financing reform. We have about 6 minutes left. I don't see any additional questions, so we're happy to hang out and wait to see if more things come up. But otherwise, thank you all so much for joining us, and please feel free to reach out to us. As Nathaniel mentioned, part of why we are having this webinar is we want to work directly with people to push this along and give more people access to the life-changing service of peer support. Just to note, this webinar was recorded, and the webinar recording and the slides will be available. And because you signed up, these will come directly to your inbox as well as being available on MHA's website.
So someone asked us just a really fascinating question. Susan asked, in the state of Connecticut, state mental health services are provided by state employees who are unionized. Are unions across the country accepting of peers? And just in general, the unions and value-based payment create really interesting situations because of the additional layer of contracting. Like when you're trying to say, like, oh, this group of providers will take on this set of incentives, but they're part of a larger union, the complexity just gets much higher. So this is an issue we're beginning to analyze, and unfortunately we don't have a specific answer to your question about the intersection between unions, peers, and value-based payment, but I think it'll be something a lot of people all have to deal with at once, and hopefully answers are forthcoming.
All right, thanks so much.